Okay. All right. So, welcome to another conversation with Swallow the Pill. My name is Zena, and I am your friendly nurse educator. And instead of doing this topic today by myself, because I know some stuff, but I don't know everything, I decided to invite an expert on the topic. Today, we are going to talk all things case management. A lot of people hear the term case management, they hear the term social work within the hospital, but I don't think they really know what it means or know what comes with that. So we have an expert here that's going to talk through some things and answer some questions. That way, we can give you the education and the knowledge that you need so that when you're in the hospital and you're requiring case management services, you can make the most appropriate decisions with education to stand behind it. So I'm going to turn it over to her so she can give her introduction and then we'll get started.
Okay, first things first. I'm not sure about experts, but I've been doing this for a long time. My name is Nidra, and I am a case manager. I've been a case manager for about maybe since 2012.
Okay.
2012, and I worked at all types of hospitals. I've also traveled in case management. I've done a lot in case management at a lot of different types of hospitals. So maybe that's why Zena gave me the expert badge. But I'm here to try to answer any questions or, dispel myths or whatever that we might have surrounding the case management department and what we do.
Yes. So let's get started. Let's jump into this. So you've been doing this a long time. I met Niger when I was traveling. She was traveling. We kind of got on the same travel company. So I noticed, and you know it from different hospitals perspectives, different state perspectives, because you
Right.
work in multiple states and all states aren't always the same.
Right.
So let's just start with a broad question. What is case management? What are you responsible for? What do you do within the hospital?
Okay, so that is like I'm gonna try to give a lay level definition of case management. Okay. It's twofold. Okay. We work for the patients in the hospital. Okay. We connect patients to services through outside the hospital. We help with discharge planning. That's our main goal. Okay. We help the patients when they are admitted to identify early on any needs or barriers that they may have to having a safe discharge. Okay. That might be something like they were just readmitted. That this is a readmission, which means they were in the hospital 2 weeks ago.
Mm-hmm.
And now you're back in the hospital. We need to find out what's going on there. Or they may be coming to the hospital multiple times about multiple things. We need to find out what's going on there. They may be living, they may be homeless
Mm-hmm.
and using a hospital as a place to live, to get care, to be warm.
Yep.
So we identify those things early that we can give them some type of interventions, give them some resources that could help them not spend majority of the time in the hospital. The second fold, and it kind of makes a circle around. We do that. We identify those barriers so that we can make sure the hospital is utilizing the patient's resources in the best way possible. If
Mm-hmm.
you come in and say your stomach is hurting, not sure why the doctor would order a foot x-ray. So we kind of keep those discharge plans and those treatment plans streamlined to where we make sure if you come in on the first day with certain diagnosis, we already know how many days you're supposed to stay in the hospital. On that first day, we need to make sure you're getting this medicine this amount of times, getting up out of the bed this amount of times. We have a specific treatment plan. And it all goes back to what? Revenue. And when I say revenue, I mean, of course, for the hospital, because at the end of the day, the hospital is still a business, but also it comes back to managing our own resources as the holder of the insurance policy. I mean, the insurance. Okay. So again, you don't want to make a patient stay in the hospital 2 days extra because they're getting CT when they came in when their finger was broke.
Right.
So we manage the resources from both ends to try to make that length of stay um, meet the predetermined length of stay,
Right.
and so that the hospital can get paid the amount that they're supposed to get paid, and that the patient won't have to pay any more than they're supposed to pay for that visit. So we're kind of like that intermediary.
Gotcha. So I
Mm-hmm.
don't think a lot of people don't realize the hospital is a business. They are not there because, oh my God, they just care so much for
Yeah.
you. They want their money and they're gonna do whatever they need to do to be able to turn that money over and to get that money back. So case managers really truly do play a very big part into that. But here's a
Absolutely.
question that I don't think people realize: are case managers nurses?
So, okay, this goes into how you said I've done um, a lot of case management over different states, different hospitals. I've been doing it for a long time. And it depends on what type of hospital you're in. I started out, I have a bachelor's and a master's in social work. Social work was my first love. And that's what I did. That's how I got into case management because I went and got an LPN degree on top of my social work. And that was like the perfect blend of the medical knowledge, like that beginning medical knowledge to know and say, okay, if a patient has a fever, you look in the chart, they need to have some type of intervention, Tylenol. And, I knew that from the small education that I had as an LPN. But the social side of dealing with families, people not understanding the system. So
Mhm.
social work gave me that background.
Gotcha.
Um, my first hospital where I learned how to be a nurse, it was a teaching hospital. And I've learned throughout the country, it seems that most teaching hospitals will allow MSWs, which is a Master of Social Work, um, family therapists,
Mhm.
um, and any type of sociology, social work type degree, as long as it's like a master's level or above, they can be a case manager. Okay. And that means right alongside with the nurses doing the same thing that the nurses are doing, managing their own caseloads. It's the same. So
Okay.
some are RNs and just strictly are RNs, and
Mhm.
some of them are MSW, have more social work background.
Okay.
Non non-teaching hospitals, I've noticed they separate the two. So you
Mm.
would have an RN working with a social worker, meaning the RN is ultimately over determining that the discharge plan is the correct plan for the patient, and the social worker actually puts that plan into place based on the social factors that the patient might be experiencing.
Okay.
So I can look at that patient and say, okay, they had a major stroke, life-changing stroke. That patient's discharge plan needs to be facility.
Mhm.
Then the social worker will be the one engage with the family, build that rapport, give them choices on what facility, explain the levels of care to them, things like that. So it just depends on what type of hospital you're at.
Mhm.
Right now, it's a big push for magnet status. That's another thing for the hospitals.
Mhm.
Like one of the accolades that they like to um, basically saying all of their nursing staff has a certain level of education.
Right.
Um, so some hospitals only hire nurses with a bachelor's degree or above. I myself don't have a bachelor's degree because nursing was my second
Mhm.
career choice. I wasn't having it. I was enough school.
Yeah.
So yes, it just depends on what type of hospital you work in, what setting you work in, whether you what your responsibilities will be.
Okay. So, question.
Mhm.
Talk about the resources that case management is responsible for. What are some of the most resources that patients should be aware of that can be offered through case management?
Mhm.
And what are some of the most underutilized resources that case management offers, and why do you think they're underutilized?
Um, the resource to me is knowledge. because a lot of times people come into the hospital and they're very guarded. Um, you know, it's a bad day in their life depending on what setting you're working in. If you work at L&D, it may not be that way. But for the most part, you have unexpected illness, sickness, injury, you're worried about money, you're not in your right mind.
Right.
So basically, I feel like the number one resource that people don't utilize is asking for the case manager in general. They
Yeah.
don't, because they don't know what they do, you
Right.
know. And then when it comes to discharge, it's like the nurse is calling you like the patient doesn't have a place to stay, they can't get their medications, they didn't do this, they can't get this, they don't have to ride home. You like, y'all should have been called me. But because the patients, they're very guarded, they don't want to be judged, or they don't want to feel like they're getting a handout, um, they don't ask for help, or they
Right.
don't ask for anything. And then you have the other patients on the other hand who ask for everything. That is not even within this admission.
Mm-hmm.
Again, you come in with a stomach ache, you're telling me that you can't get your mental health medication filled.
Right.
How long has this been going on? 8 months. This is an acute care hot, meaning right now. What's going on with you right now? Let me help you with what's going on right now.
Yeah.
So I think the knowledge is the part. I think a lot of people don't want to be judged, so they just don't ask for help. Again, the hospital that I learned how to be a case manager at, it was a urban core hospital. It was the city hospital, but they had the affiliation with a big university where I was from. And so they treated all types of patients, and they had all types of resources. If you don't even have to ask. You
Mm-hmm.
can just mention to a case manager that, hey, I keep getting admitted because I can't get my prescriptions filled.
Right.
That's gonna prompt them to say, well, why? Do you not have I prime example, patient, they need a ride home. You set up an ambulance to take them home and put them in their home. They didn't have a chance to pick up their medicine because the ambulance is not going to take them to get any medicine. So small things like that, the patient, they don't have a blood medication. They are pre-op. They don't have any pain medication. So that's going to bring them back to the hospital. That's what we are there to prevent.
Yeah.
So for me, it's just the simple thing of asking or
Mhm.
tell, hey, I keep coming back to the hospital because I don't have rides to my appointment. Um, I keep I keep having COPD exacerbations because I stay in a place in a shared living space, and they're all smoking.
Right.
Just the dialogue and the conversation, I feel like, is the underutilized resource, because again, they don't know that we exist and know what we do. When people hear casework or case management, they automatically think of kids, so they don't even understand our place in the.
Yeah.
But if you just share with someone, hey, this is what's going on, like have that real conversation, which is sometimes hard because you have 5 minutes to talk to them, they're in and out, you don't get to build a rapport with them all the time. So I would just say ask.
Yes.
Let them know when they're asking you questions, be truthful. We're not here to judge you or, you
Mhm.
know, take your kids away or anything like that. We are here to identify actual factual barriers to your discharge or reasons why you are constantly readmitted. So that's what I would say.
Just listening to you talk, one of the biggest two things I would suggest for nurses, in particular, that are still at the bedside, doesn't matter what area of nursing you're in, when you have those patients come in as a nurse
You
at
know,
the hospital that I work at, I can't speak for all hospitals, but current hospital that I work at, we don't need a doctor's order to consult case management. We
no,
automatically put that consult in based off of our nursing judgment. So if you
absolutely.
have a patient come in that you know is having some sort of struggle, just go ahead and put that order in, and let case management come in and make that contact, and they can begin to have those conversations with patients to discuss what they need, what they might can help with, and go
Mhm.
from there, and not waiting until discharge to say, oh, maybe we should get. No, you can put that conversation
Right.
beginning, and
Right.
whatever happens, case management will follow them throughout the hospital.
Right. And
Um,
whatever floor, the patients don't know that everyone has a case manager on admission, period.
right.
Now, we do have to do some prioritizing on who we see first based on the floor that we're on. So
Mhm.
if you have a young patient, um, you know, a minor injury, a walkie-talkie, they have insurance, that person is going to go to the bottom of your list because they're the least likely to get readmitted or need some help. But if you know your patient is admitted and they have 3 bags with them, they probably don't have a place to live. Or if they have on an old dressing,
Mhm.
they probably need case management. Or if they say they came from a nursing home,
Mhm.
they probably need case management. So those are some things to look for. You know, as a bedside nurse, that may not always, you know, connect the need. I've had so many people tell me, I didn't even really think you do anything, or I didn't even really know what you do. And
Mhm.
I'd be like, girl, you have no idea. I be here working. So
I
yeah.
remember being in Arizona one time, and I had this patient. It was crystal clear she was in a domestic violence situation at home.
Mhm.
And she kind of expressed that without expressing that on admission. And so we consulted case management. And at
Mhm.
that time, I didn't even realize case management did any of that stuff. And they did step in to talk to her. Um,
Mhm.
the police was called uh,
Yeah.
because it was a real situation, and she wasn't ready. The patient was not ready to be out of that situation, but case
Right.
management did step in to try to help.
Okay.
So I don't think people realize case management also helps with domestic violence stuff. So if you see someone that come in and things look questionable, case
Mhm.
management can be the resource to answer those questions if you're not sure, because
Right.
reach out to them and they will come.
Exactly. And we have to address those things.
Mhm.
That's a part of our day-to-day job. We have to address if a nurse or a doctor, anybody brings things up to us, um, human trafficking,
Mhm.
domestic violence, child abuse. We have to look into those things. So if you have any type of questions, now again, it's a little bit of a moral dilemma sometimes because you do want to jump in and just yank the person out. But like you said, if they're not ready,
Mhm.
you did what you could do, and you did what you mandated to do, in good faith, and then you just have to move on from it.
Right.
Mm-hmm.
So, being that, I feel like nursing is changing, just from what I'm seeing. Nursing is shifting once again.
Mm-hmm.
What are you seeing from patients? What are you seeing from nurses? What are you seeing from doctors currently where you are that you would like to speak to and just kind of give some advice to as a case manager?
Um, I feel like we see it all really, but I feel like with the advent of you know, maybe social media
Mhm.
and the thought process of right now society,
Mhm.
um, a lot of times that kind of directs how a patient is treated, or
Mhm.
um how they're viewed, or how the medical team interacts with them.
Mhm.
um you can tell, I won't say it's entitlement, but the focus on maybe non-traditional medicine, or like they come in the hospital and they're like, well, I saw this on Google, or I saw this on WebMD, or I saw this, and it's like, you know. And
Right.
then I think too, from uh I'm not on bedside, but from a bedside point of view, it's almost like the nurses or the doctors might be afraid in some capacities to do certain things because people are quick to pull out a phone, or
Mhm.
people are quick to be litigious and say that they're going to sue somebody,
Mhm.
and really like amp it up, and then before you know it, you was just going to work. And the
Right.
next thing you know, you all over social media, but they only show that small portion, that small clip for to people who don't know how the hospital works,
Right.
and knowing that the doctor was well within their rights. I also think that insurance plays a big, huge part.
Mm-hmm.
Um, and it's insane. I work at a orthopedic hospital, so we perform orthopedic, spine, joints, hips, all that. I'm in a big city known for medical. They're medical, so it's not like an acute care hospital. If you fall down the stairs, they're gonna take you to the closest hospital. No, these people choose these doctors. They build relationships with them.
Yes.
They Their grandfather had their knee replaced by him. We have, our NBA teams, NFL teams come to that hospital, and it's almost like a concierge type experience.
Mm-hmm.
Um, and it's challenging because um, with the insurance, let's go back with the insurance. When I first became a case manager, I know that if you came in the hospital um, for a knee replacement, you're probably going to stay 3 to 5 days minimum, right?
Mm-hmm.
Because we're all on the Medicare, what's called the Medicare inpatient list. Won't get too much into that because it's just jargon, medical jargon. But it's a rule, it's a list that says if you have these this is what Medicare is going to pay for them, and these is how many days that they can stay.
Mm-hmm.
Um, that was about 10 years ago.
Okay.
About 7 years ago, I would say they took all the orthopedic surgeries off the inpatient only list. So all the orthopedic surgeries are outpatient surgeries.
With that.
Outpatient, okay? Meaning I'm 44, relatively healthy, don't have any really other medical problems. If they do my surgery downstairs, they do my therapy downstairs, I can just go from there.
Mm-hmm.
That same surgery, a 72-year-old with some problems, they expect that same 72-year-old to
Yeah.
get on the operating table, have that same surgery, and walk out of here no later than 24 hours after the surgery. You could keep them there, but this is all we're gonna pay you for that, for that. And it's hard. Doctors are caught between a rock and a hard place because again, they want to provide certain level of customer service, a certain level of custom service again because they chose this hospital.
Yeah.
But you can't do that when you're in a restriction with what the hospital is going to get paid for. So
Right.
sometimes it's an ethical dilemma for me because the doc like I have some patients on a outpatient surgery and they come with like bags and say the doctor said I can stay here for 4 days. You
Yeah.
can't even stay here for one day. And so the doctor doesn't address it. So who do they call?
Yep.
And then I it's a fine line. If it
Mm-hmm.
was care, I can just say, hey, you're ready to go. Your vitals are stable. You came in for this. It's now resolved. We have a follow up for you. We have meds to the bed. We have your medicine for you. These are all the interventions that we put in place. You're discharged.
Yeah.
Goodbye. You can't do that at this hospital because they have a certain level. Some patients come from out of town, Louisiana, to see these doctors, rent homes for 6 months in the city just to see this doctor.
Yeah.
And so that's kind of like what I'm seeing. The trend in medicine is that, you know, I guess the insurance makes it so that, you have to keep the patients for a certain amount of time, or let them be discharged at a certain amount of time. And the doctors having to work within that, and they don't. And then it's just on me to like push the patient out.
Yeah.
So it's like, it's a lot. It's hard to be ruled by the insurance that, a lot of times they don't have the medical perspective.
Right.
They don't have, um, you know, they don't know that this person is going home by themselves and they're 94 years old.
Yeah.
That's not pulling on their heartstrings. They're not at home in bed thinking like, oh my God, did Miss Martha make it home safe? So that is definitely a trend that I'm seeing. Case management.
I don't think people consider just how much insurance companies play a part in healthcare because they're kind of like an invisible factor that you don't think about, but they play a very, very, very big part. And I think if people knew more about the insurance companies that they was actually paying premiums on, they would actually be more responsive to certain things.
Absolutely.
In your opinion, you would say yes or no that insurance companies truly do make or break the outcome of.
In certain situations, I have a lot of people that say, oh, because I have Medicaid, y'all trying to keep me out. It's not that. It's not in that situation. The haves and the have-nots, it's not anything like that.
Right.
So it's not like, you know, Medicaid is not going to pay for something and they're going to kick you out versus a commercial insurance or whatever. It's not in that way, but insurance literally, quite literally, drives your care from the time you hit the door.
Mm-hmm.
Okay. We don't see this too much here, but like California, they have hospital systems.
Mm-hmm.
So um again, you fall down the stairs, you're next to Kaiser. They're gonna take you to Kaiser.
Mm-hmm.
But you have a different insurance. Kaiser cannot see you. Or you go to another hospital and you have Kaiser, you can't be treated there. So
Right.
from the time that you walk into the door, the case management manager is like, get them out because the hospital is not being paid for your care.
Right.
So once we connect with the hospital that you're supposed to be at and you get over there, then you can be treated for actually what you came in for. I mean, down to the point where, say you have an infection, you have your cultures drawn, you're supposed to go home on that. Some drug plans, daptomycin can be a $500 a week copay at home.
Wow.
No one has money for that. So what do? They put you on something lower,
Mm-hmm.
cheaper,
Cheaper.
because your insurance is going to pay for it. It's less effective, and you're going to be back in the hospital in 2 weeks because it's not going to work.
I
So
don't.
it literally drives every single solitary choice. And I think a lot of nurses on the floor, they don't get that because they focus on what they do. And
Mm-hmm.
the case management's up to us. But there's a reason why the doctor mid admission switched your patient from that daptomycin
Yes.
to another drug. It's a reason why they did that.
Yeah.
Because they need to go home on something different. Or I have patients that live in very rural areas,
Mm-hmm.
and um, I won't say any insurance's names because I don't know them exactly like that. But like say insurance A, they go into the rural communities and they recruit the patients. They say we can give you this, we can offer this, we can do that, da 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 da. The patient signs up because I've seen a healthy decline in straight Medicare over the years. People have the HMOs, all of that,
Mm-hmm.
which they're brand related. So people are like, okay, well, I had Aetna my whole life. I like these doctors. So when I go to retire, I'm going to get Aetna Medicare because I'm familiar with the brand name and I can keep all my doctors. But what they're not thinking about is you live in a rural community, right?
Mm-hmm.
Now you're on care. You might need home health. You might need therapy to come out to your house for you. They go into these rural communities selling these plans. And then when it's time for the patient to get those services, they don't have not one provider in that area. None. And it's like, to me, it seems so like counterproductive to do that and to make the patients feel like they have this safety net because you saved them $20 on the medication all year and now they really need it. And it's like, okay, I don't I don't know.
Wow.
Yeah.
Man.
Right.
That is a lot.
Yeah.
So I'm not going to hold you much longer. My question would be, any advice you would have for anyone that is considering case management as a career?
Yes. So my advice would be to um go into it. Okay, you got to get your experience on the floor first, of course. Go into it with a collaborative mindset, because basically that's what you're there for. You're in the middle of this chaos, right? The patient is sick, their dog is dying, they're about to get the divorce, their lab's not coming back good, they're about to lose their job. You're in the middle of all of this, and you're the team, the person that brings the team together. Okay. Oncology might want to do this, CT might want to do this. It's what heads, but you're the center of it all. So you, the patient, is the center of it all, but you're coming together with everyone. So if you go into it, have a collaborative spirit, and know that you are all working together for patient. Okay. Um, One of my mantras, because I used to get so stressed out, like this patient need this, the insurance won't need pay for this, that, and the third. But one of my mantras is, I cannot create magic. I am here to provide the patient with the best possible services within their best possible resources. So at a certain point, it's all I can do. You know, you have to keep in mind just teamwork all around, because again, you're going to get in those situations where um, there's no workflow for some of the things that you are going to encounter. So you have to be creative. Want to learn, live, work in a fast-paced environment where things can change at the drop of a dime. Um, I would say, come on over to case management. If you just really like working, I really enjoy the aspect that you're really, really affecting change fast, and you're behind the scenes. You don't even never necessarily have to meet the patient for more than 5 minutes, but you really made a difference in their life. So if you're looking for something like that, maybe a little bit away from the bedside, Monday through Friday, 8 to 5, no holidays, no weekends, case management is for you.
Well, I thank you so much for
You're welcome.
education on me, on the nurses, on the patients, just giving us all that you know, and all that you have experienced. I am so thankful for being able to chat with you.
You too. Thank
And
you so much for having me.
you're welcome. We do something again for sure.
Yes, definitely. Definitely another collaboration.
And as always, guys, thank you for watching, and swallow the pill and be well.